Why do so many ineffective treatments seem to help? The history of medicine is filled with bizarre and at times barbaric practices. Why would people voluntarily engage with these for centuries? They must have been seemingly helpful at the time. The process of bloodletting, for example, was one of the most popular interventions in medical history. Even George Washington, the first US president, in his final days had 40% of his blood drained by top physicians to treat him for a suspected infection, whilst it probably just accelerated his death. So where is medicine today when it comes to ineffective practices, also described as low-value care? Well, one study showed only a quarter of newly approved drugs confer any significant added benefit. In studies of cancer treatments brought to market in the US and Europe, after years of continued use, only around 15% were subsequently shown to provide any benefit in survival or quality of life. Another study found only 18% of primary care recommendations were based on high-quality evidence. Interestingly, diagnostic tests are a key area of evidence low-value practice. And in a review of 363 studies examining current standards of care, almost half of these were shown to be ineffective. This aligns with views of primary care clinicians who considered around 38% of medical services as representing low value. And in this study of a US health system, at least a quarter of patients received low-value interventions that provide little to no benefit. Regardless of the exact proportion, ineffective practices, whether tests, screening, drugs, surgeries, or other therapies, are clearly far from rare and something that many of us unknowingly receive. However, despite strong guidance from numerous institutions and working groups around the world to abandon ineffective or harmful practices, evidence shows such recommendations do little to change clinician behaviors. So why is it that well-meaning doctors and patients continue to think that so many disproven tests or therapies help, when research shows that they don't? The brilliant late psychologist Scott Lilienfeld explored why so many ineffective psychotherapies are perceived as helpful. He developed a taxonomy for what he described as causes of spurious therapeutic effectiveness, which is applicable to many areas of healthcare. Category 1 is where there has been no improvement in someone's condition, but an improvement is perceived. This can be due to selective memory and attentional biases in the information we focus on, a tendency to remember pre-treatment status as worse than it was, or patients reporting what they think the clinician wants to hear. Category 2 is where things have improved, but due to other factors unrelated to the treatment in question. For example, multi-treatment interference, where patients may be receiving several therapies simultaneously, and it is hard to know which genuinely helped. Or regression to the mean, as many chronic conditions fluctuate, but statistically return to their average level from their extreme states. However, it is at extreme points when patients often present to clinicians seeking an intervention. Illnesses also often have a self-limiting nature. For example, the majority of respiratory infections usually resolve within around 2 weeks without antibiotics. However, patients often present just prior to this turning point, receive antibiotics, and subsequently assume they only improve because of the medicine. And finally, category 3, where things have improved due to the treatment, but from non-specific treatment factors. This includes novelty effects due to the anticipation of receiving a new treatment, or effort justification, where individuals may persuade themselves the therapy was beneficial to justify the investment of time, effort, or money, and of course, placebo. Across hundreds of studies, placebo effects can be variable and sometimes small, but particularly when it comes to patient-reported outcomes measured on continuous scales, for example pain, placebo effects may be clinically meaningful. These two systematic reviews, including this one of 152 randomized studies comparing active treatment, placebo, and no treatment groups, showed there is often little difference between the effect size of active medical treatments and placebo treatments. The value of placebo is debatable, as proponents may argue such therapies fulfill our biases of a compulsion towards action in clinical practice and do help, just not via the mechanism expected. We therefore need to consider the opportunity costs and adverse effects when deploying such placebo-type interventions. Lilienfeld outlined 4 key cognitive impediments underlying these categories of faulty reasoning of a clinical benefit when one doesn't exist. 1. Naive realism, the assumption that the world is precisely as we see it. Paraphrased, what you see is what you get. We have a tendency to attribute any outcome to whatever happened just before it, a cognitive fallacy with its own Latin label, post hoc, ergo propter hoc, after this, therefore because of this. 2. Confirmation bias, our tendency to observe, interpret, and remember information which fits with our pre-held beliefs, desires, and expectations, whilst we deny, dismiss, or distort evidence that is not. Patients, clinicians, and even researchers fall prey to this. And 3. Illusory causation, our propensity to perceive cause and effect between variables, particularly those that we're paying attention to, even though it does not exist. And 4. Illusion of control. This is the way in which we can overestimate our ability to influence events. This can predispose clinicians to believe they have more power over patient outcomes than they do. This is all reflected by a systematic review of 48 studies, including over 13,000 clinicians across numerous specialities, where most were able to accurately estimate the benefit of only 11% of outcomes following healthcare interventions. Clinicians mostly overestimate the benefit and underestimate the harms of healthcare practices. Of course, there are plenty of other psychological, commercial, or system drivers for the gap between science and clinical practice, and the overuse of low-value treatments. But these categories map out why we cannot solely rely on our informal observations. or personal experiences, which are a poor guide to the effectiveness of treatments. Research methods can help. For example, the randomized control trial is a standard for understanding cause and effect between a treatment and outcome. This is where individuals are randomized to receive either a treatment or an alternative approach, often placebo, and their outcomes are compared. Ideally, both the participants and observers are blinded as to which treatment was received, and random allocation can help eliminate confounders such as selection biases. However, such RCTs are not always available or practical. When there is no high-quality evidence, we should be weary of, in my experience, recommendations, especially when there may be opportunity costs involved. Personal observations can of course sometimes be correct and useful signposts, but because of these faulty inferences in our reasoning, we need humility and awareness of our tendency towards overconfidence and misinterpretation of cause and effect in healthcare, and to apply a high bar of scrutiny to what we devote our scarce personal and system resources towards. And even in your own experience, that amazing pill, concoction, or therapy that appeared to solve your symptoms, be aware that maybe it didn't.